Here. Welcome to meeting number 3. Thank you everyone for getting here. We're hoping karmically that we have good, not squeaky microphone today and no bomb threats. So that's our goals to skip that part today. I so far so good with the microphone. I want to go ahead and get us started. We have had a couple of work group members have to stay behind today because they've had some bills come up for hearing, and then there's also a nasty bug that's sweeping around. So one of our facilitators, one of our note takers is down, and a couple of our work group members. So happy that they all kept their germs to themselves, but we did do a little reshuffling today. So we're going to be doing 4 breakout groups instead of 5. I'm going to walk you through our agenda. We've also made a couple of changes on the timing for our agenda, so I'll let you know about that as well. Our main meeting objectives today, and just a reminder, I'm Jamie Strauss-Clark. Nice to see all of you again. A reminder of our meeting objectives today. Key is we want to come out of this meeting with some refined assessment criteria based on our breakout group discussions. You've received a draft to react to, and we're going to do some breakout discussions around the assessment criteria by which we're going to eventually evaluate different models of universal health care. We're also going to learn about different models of universal health care at a high level. And then between today's meeting and our meeting in April, you're going to have an opportunity to provide input on which of those models we're going to evaluate and compare. We're going to confirm action items and next steps, and then finally have our public comment. So that's the agenda for today. We did make a couple of adjustments because after I sent out the materials for the meeting on Friday, I got some feedback from some of you, and so we decided to make some adjustments to allow for more time for those assessment criteria discussions. So we are not going to be doing the icebreaker today. So I know that's something that some of you like to have, but we're going to skip that today. I know, really, sorry to hear it. I can tell from Ronnie and Aaron that you're really going to miss that one. Couple of things I want to remind you of, what we've done to date and where we're going. We, as you know, at our December meeting, discussed root causes as well as a problem statement for healthcare, the current state of healthcare. Because of that, having to end the meeting early because of that bomb scare, we had to improvise a little bit about, or the bomb threat, we had to improvise a little bit about pulling that all together since we didn't get to do the big finish and the report out. But what we have now are those root causes, some consolidated problem statements, and those are still living documents, so please know that I'm still happy and interested in taking your input if things come up for you. In fact, I just got some input from Kelly last night. So please do continue to send me your input and we'll continue to refine those. The next step after we work on our assessment criteria, the next step at our April meeting is to settle on some models of universal health care to evaluate and compare, and also for our actuaries to start their analysis. And then we're going to be working together as a group, evaluating and comparing different models of universal health care. We're going to be doing that for 3 meetings, and then we're going to start putting together that final report that goes to the legislature, including what are the necessary next steps to keep this ball moving forward. So that's where we are and where we're going. I'm going to stop talking because I want to make sure our chair has an opportunity to say welcome and any messages that she has.
Yeah, I just want to welcome everybody to our location today. Thank you for adventuring with us out here. Those of us that are still a little new to the area did lap, so that was it was good to get us started. More importantly, thank you for your ongoing commitment and your attendance in this process, all of the work you're putting into it in between meetings, because we are getting your comments, getting your thoughts, and we just so appreciate all the participation. And we need to just remember that we've got to be patient with this process as we're journeying along, because there are some very big bodies of work we have to do, as you know, that lie before us. But I really think that the collective energy and the participation and your wisdom as we go forward will pool into great successes as we keep journeying further. So really, that's it. And I know we're very squished for time with all we got to cover, so I'm turning it back to you.
Oh, Yes, thank you, Liz. We're sending around a sign-in form, so please do note your attendance on the sign-in form. It's how we also make sure the notes are accurate. I do want to make a couple of notes. First of all, welcome our members of the public who also ventured out here to be with us today, some coming from quite far on airplanes. I am going to ask, we're going to be doing breakout groups today, and I know we didn't talk about this last time, so I want to reiterate. Breakout groups are going to be in the corners of the room. I think this room has much better acoustics than the room we were in last time, so hopefully you'll be able to hear each other much better, and our members of the public who are joining us will be able to hear much better. I am going to ask when you break out into your groups that work group members sit at the tables and bring your table tents with you, and then that our members of the public, we've set up some chairs on the perimeter there. Please make yourself comfortable in one of those chairs. And a reminder that during deliberations, work group members and facilitators are talking. I'm going to ask members of the public to be observing but not participating in the discussions. But, of course, we will have our public comment period at the end of the meeting. There's a sign-in form at the table here, so please do sign up. A quick reminder of our public comment process. Sign up, we're going to go in the order of how they're listed on the sign-in form. We'll have 20 minutes, and we're going to do a 2-minute time limit on each public comment to make sure we give everyone who wants to comment an opportunity. I do have a timer on my computer, and I'll just show you how that works. But I'm going to ask you to stick to that 2-minute limit. You'll get a little warning letting you know when your time is almost up. And if you have any written comments that you'd like to share, that'll help us keep it in the record. Finally, we have committed to sharing public comments, both what you hear here, but also what is being posted online to this group. I understand that you have not actually received copies. I just spoke with the team over here. We're going to email you all the public comments to date early next week, I think is when we're going to be able to do that since this is Friday. So early next week you'll get those. And then the plan is moving forward to get those to you when we get the meeting materials to you in advance, because we understand that reading those public comments before the meeting is actually going to be more helpful than reading them after. So from now on you will get them before the meeting, not after. Any questions before we move on? Okay. Then let's, I'm looking at our groups here, and this is actually even smaller, so I'm just going to take a quick inventory here of who we have, because I'm wondering if we have enough for our groups. I think for our small groups? Okay, I think I'm going to ask everyone to go to your groups, and then we'll see if we need to do any additional reshuffling. Yeah. So we have 4 groups, breakout groups. We've mixed you up a little bit, but again, trying to get people representing different sectors in each group. And we have 4 facilitators. So we have Gary, Rochelle, Liz, and I will be facilitating the groups. You're going to be doing 2 exercises in the breakout group. The first is going to be a vision of what the world will look like when we achieve universal health care. It's for us to talk about the conditions you'd like to see. And then we're going to use that to have a discussion about the assessment criteria and how you would like to propose modifications to that draft assessment criteria that you received. Now, a reminder that draft assessment criteria is purely something for you to react to. I understand that some of you might say, check it out and start over again, and that's fine. We don't want to give you a blank piece of paper to work with. We want to give you something to start with. And that assessment criteria was developed based on the root cause work that you did and other feedback that people in the work groups have provided, in addition to reviewing other ways that it's been done in other places, including that RAND study in Oregon. So we're going to have a little over an hour to do that. Then we're going to get a report out period. And we're going to make it to report out today, where we're going to have a chance for you to go around and see what the other groups came up with, and then come back together in this large group and have a discussion. And then we'll move into the discussion about the universal healthcare models. So if everyone can get up, you have on your table tents colors denoting which group you're going to go to. Blue is in that back left corner, well, my left corner back here. Yellow is in the back right corner. I'm sorry, orange is in the back right corner. Yellow is up here on the left. And green is over here. So if everyone can get up, and please take your table tents with you. Work group members sit at the tables, and members of the public, please feel free to sit behind. And then I will send our note takers to each group. Okay, before we get started with reporting out, the facilitators are going to report out. some highlights. But before we get started with that, I just want to ask what you observed when you went around. Did anyone, first of all, have any questions or confusion about some things that you saw up there? Anything that didn't make sense to you? Okay, so the note takers did a great job scribing. Excellent. Any common themes that you noted, things that you saw frequently, maybe at all three groups or two out of the three groups? Not one common theme? I saw culturally tuned care at all three groups. That was the model needs to be enhancing or in some way of enhancing or encouraging culturally tuned care. I also saw evidence-based at each of the three groups, so enhancing or encouraging evidence-based care. Yeah, Kelly, do you mind turning on?
I admit I was just looking for the things that we didn't have in our group, so that maybe some other people did that.
So what did you note?
We didn't have that this is going to require a public relations and patient education piece, huge, which is really, that's super true. And there was more talk about governance and accountability. Now I can't read my own writing, but the governance and accountability issues. And I can tell one group had a lot of good stickers about rural care. And there was some really interesting stuff about data collection and reporting adverse incidents.
Death, infection.
Yeah.
That was
interesting.
You caught some good stuff.
Yeah.
Any other things that folks noted? We'll do a full report. I just want to get your initial reactions. Okay, let's start with we'll start with the yellow groups report out. And the way we're going to do this is I'm going to share some of the modifications that we came up with, and then the other two groups are going to build on that. So I'm not going to ask you to read my chicken scratch here. I'm just going to use it for prompting me. So in terms of what populations are covered, and also, I'm sorry, in terms of governance and I think I'll stick with governance, that the model allows for phasing and incremental advances toward universal health care. So that was something that we talked about. I didn't see necessarily in the other groups, but the idea being that it's not just that end state that we're trying to achieve, but the model actually allows us to take steps to get there and improve the quality of health care that people are experiencing in the meantime. We had a lot of conversations about quality in our group, and so we would say that would probably fall under other considerations in the criteria, but enhancing quality, transparency about provider quality, reductions in variability of care, and reporting out adverse events. Kelly caught that one. Those are all measures that we would like to see on the evaluation criteria or the assessment criteria. Is this model amenable to data sharing and portability? So does this model actually support making data both at the individual patient level and at the larger public health macro level able to be integrated and shared? And another point is, does this model allow the patient to have a voice? And Bevan, do you mind just explaining a little more? I'm sorry. I'll come back to you. You good? Okay.
Whoa, that's really loud. Really, I just wanted to make sure that there is some sort of central location where patients can interact with the system itself, so that as we kind of innovate and grow as a system and as a culture and as a society, we're making sure that we also have the patient's voice kind of at the center of what quality means and how we make it better and how we make it more culturally attuned. So I think there's all kinds of amazing technological innovation out there these days. So some way for patients to feel connected to the process.
Thank you for articulating that better than I could. Another quality measure we talked about was, does the system allow for quality delivery in rural areas across different cultural, ethnic, and language communities? And then there's an et cetera here. There are probably other groups that should be listed here in terms of differences in how healthcare can be delivered to get quality outcomes. is the system amenable to value-based design? And what we meant here is, this was when we were talking about evidence-based care, but the high-value, cost-effective care like preventative care and some of the immunizations, for example. We did note that communities, similar to our previous comment, communities, tribes, for example, if Aaron Spark was here, I'm sure he would say this, and other communities may define evidence differently. So we talked about this at our last meeting, that a lot of studies have been done with very narrow populations, white males, for example. And so evidence may look different or be different for different communities. Our whole quality discussion got started with a question about how we measure quality. So that's, I think, a trick we're going to have to navigate as we're developing these assessment criteria and then using them to measure. We did talk about benefits packages, and a suggestion was made that instead of having this very expansive list in these evaluation criteria, that because so much work was done in 93, 94 by the Healthcare Commission on a benefits package, that we might not reinvent the wheel, not spend a lot of this group's time on that, but actually use that material first. There was a suggestion to simplify the cost section, and instead of talking about costs in terms of premiums and participant co-payments, talk about it from the perspective of each category. So for example, from the perspective of providers, or from the patient, or from the state or taxpayers. And finally, the additional criteria would be, is this system amenable to administrative simplification? The proposal was to simplify the feasibility administrative section to just this question about administrative simplification. So, any questions before we move on to the next group? Yes, Sue.
On the benefit package, I think we should note that that would take us backwards from where we currently are going with a standard, the standard benefit. So, while that's a base, I think the standard benefit that is now in play and moving forward under Cascade Care and with HBE,
Right, it's
that would take us backwards in the state.
Okay, so if we look at
Somebody needs to look at that, because the standard benefit now is better than EHB, which that work was based off, is my understanding.
well, that actually predated EHB.
Oh, okay, that's BHP.
This goes way back.
Okay, so let's go to use our table 10 string on the side, because I do want to have a quick discussion about this. And Denny, if you have anything to add, but Aaron, sounds like you have a reaction to that. I heard you say no.
Yeah, well, no, sorry. The Healthcare Commission benefit package was not based on BHP. So, in fact, the Healthcare Commission benefit package was based on a philosophy, if I remember the words correctly, more comprehensive than not. So the idea was very much to cover all of the services that people would need in order to be healed or supported to their optimal functioning. So it was definitely not BHP.
No, I
So-
said EHB, but anyways, go ahead.
So
Essential health benefits.
Aaron, to clarify, just to make sure for everyone's understanding,
Right.
you're saying you disagree with the point that it would take us
Well, I
backward.
think it might have been based upon mishearing, because she said
That's
EHB,
possible.
essential health benefits. But I would note that I helped design that benefit package, which dates me obviously, but it costed out to, I think, $139 PM for the entire state. Not because we were so clever in what we designed, it's just that healthcare has changed a lot since then, and it's gotten a lot more expensive. So we just need to be cautious to.
My point
So,
is just
Pam,
we
I
need
wanna
to
make sure-
understand the new standard of standard benefit.
Right.
Which Pam can school us all on.
Right.
Okay, so Pam, I want to go back to your point that you just made, which is that because healthcare has changed so much in the nearly 20 years since that was
Right.
developed,
Right.
20 years, 30, since that was developed,
Yeah, more than
that
20.
may not be the right basis for.
Well, I think.
But we should be cautious about
Yeah,
it.
we
And I think that echoes, okay.
Yeah.
So I'm going to make a note here that I think the takeaway, and Denny, tell me if I should interpret this differently. The takeaway from our discussion in the yellow group is that much work has been done on benefits packages. And so rather than this group spending a lot of time on that, we can build on work that's already been done. Possibly that package, but it sounds like there's some cautions we should attach to that. Denny, before we move on, do you have anything to add to that since it was your original idea? That's what I'm hearing the same thing. Yeah. I'm hearing there's a caution in going back to the 93, 94 package, but I'm also hearing that there's interest in building on something that's already been
Well,
worked on and developed.
correct. There've been efforts since then, and I think your point is we need to look at all of those.
Okay.
Right.
Okay, let's move on to our orange group, who's going to build on the report out that I just gave. So they're going to tell us about what they might have done differently or in addition to what we did in the yellow group. Do you want me to hold it up?
So from the first bucket, what populations are covered, there's a piece here talking about having a mandate, so that the conversation really being that in current environment you have enrollment periods. We go into something else. Kind of the takeaway is that we want to make sure that everybody has access, and if you, in some future state, miss an enrollment period, that all Washington residents kind of are covered under that mandate. Additional definition, I think, for all Washington residents to really capture that we're capturing all people, immigrants, and all those people that aren't currently covered in health insurance, that we're capturing them in that definition, that broader definition. Under benefit packages, again, I think the only other kind of addition is the social determinants of health piece. So really those benefits or those social determinants of health that are evidence-based, that those, to demonstrate that those have some sort of cost savings, that those would be included in whatever this base kind of health benefit package is. I think the other big piece is gender affirming care as a piece of capturing under the benefit package. Does that capture sentiments of the group? So provides access to what? Again, evidence-based as an addition. This piece about least restrictive environment, kind of focusing on, as an example, for example, this over-medicalization of our delivery system, that we're getting people to those least restrictive environments for care. And I think and again, reiteration of the other considerations of this over-medicalization piece. Shift of the language or the terminology on the backside when we're talking about promotes primary care. We're talking about really promoting the preventative health system. I thought it was of note that we left out BRIE and HTCC. I think those are the big pieces that were additional. I'll have to speak to the group.
Okay, I heard the BRIE Collaborative and the Health Technology Commission. Other questions about what you just heard on that report out? Does anyone from the Orange Group have anything to add or enhance there? Oh, I'm sorry, Bevan, yes.
I just wanted some clarity on the over-medicalization. Can somebody clarify that a little bit?
So Bevan's asking what was meant.
It's like
in that group.
over-prescribing, or is it, what was the key on that one?
So group members help me out, but there's often times where we may be doing too many procedures, or we automatically jump to psychiatric admissions in a institutional placement versus having enough capacity in kind of community-based systems. There's many examples. Oftentimes there are lots of C-sections done unnecessarily, and maybe there are other environments that are much more cost effective, but there might not be that ability for people to have some of those lesser environments. They're not lesser, but they're less costly, so I don't mean that on a quality statement, but that was part of the discussion. There's a lot of waste in the system.
I missed you. Okay. Anything to add to what Sue was clarifying on over-medicalization?
Well, I'd like to add, too, I wish this were my idea, I think it was Sue's, of so many of our mentally ill people end up in jail. That's highly inappropriate and too costly. I know when I work with the homeless population in Spokane, too often they look to go to the emergency room. And we're going, no, you're here in the clinic. We can take care of that. You're fine. It's just, I think Sue made a really good point about this over-medicalization when it's really more of a getting a house, making sure you have the right food, that your medications are refilled. Yeah.
So it sounds like this group also drew a strong link between the social determinants of health and the outcomes over medicalization. Okay. That's an interesting point and different from what was done in other groups. Bevan, does that clarify the over-medicalization for you? Any other additions that folks in the Orange Group want to add or clarify? Yes, Dr. Dietering.
I think a phrase that sometimes brings that together is right care, right place. So, you're doing the right thing in the right environment, the least costly environment to do the procedure, whatever it is. So that's kind of a way of maybe talking about that makes it a little bit easier to understand.
Well, and it sounds like that might capture some of the other ideas that were presented, like in the initial group about cost-effective or value-based care, if I'm hearing that correctly. Okay, so if I'm thinking of this in terms of modifying the criteria, it sounds like we're looking at, does this model support the reduction in over-medicalization as an outcome? And then maybe something along the lines of, does this model support investing in social determinants of health that would prevent over-medicalization, something along those lines? Is that accurate? Okay. Any other questions about what you heard from the Orange Group, or any additions or clarifications? Okay, then Nora, you want to give it a shot? We can probably just, I'll grab your easel for you.
Thanks. Actually, it will be useful to see, but I think because so many of the themes that were brought out in the first two groups are really similar, I wanted to focus on a couple of things. One is that we, after talking about what does the future state look like, what would a successful end state look like, we used those notes and the document about different priorities to kind of go through the areas of priority to say, what do we think is, are we matching up the things that we think of end state that we would then use to compare against each of the models that we might look at and say, how do they stack up to these things? And obviously a lot of these things are really similar to what everyone else said. I think the key thing is that this group was very thoughtful about thinking about these things very holistically, and I think that this comes through both in terms of, saying not just all state residents, but thinking about that in terms of age, geography, income, et cetera, sort of thinking about the range of ways that populations are involved. And then for benefits, thinking about it in terms of being whole body coverage, being holistic, and thinking about, again, services, that are needed when they're needed, et cetera. And that includes cultural attunement and particularly looking at the benefit that services have for communities. And then one of the really key things that we looked at was in talking about cost and affordability, we talked about looking for evidence of cost control that doesn't compromise access and quality. And so keeping both of those things in mind at the same time. Is obviously you have this goal of cost containment and making it financially sustainable for individuals, for governance, for providers, but at the same time making sure that people are getting the services that they need. And then a real focus both on governance being more accountable, more transparent, making sure that that we are being as administratively streamlined as possible, thinking about it in terms of how do we make it easier kind of across the board using the governance structure. And then recognizing that political and other feasibility are really going to be important, and recognizing that that might mean that it takes time to get to where we need to go. And yes, people were very interested in the economic impact on the state and otherwise.
Okay, so any questions or comments on what the Green Group did? Okay, I have a couple questions for you. So the Yellow Group had a specific proposal, and I want to get your reaction to it. If you remember, under the cost and affordability section, the Yellow Group had proposed simplifying all of these individual criteria and focusing instead on the listing criteria that reflects the perspective of a group. So, for example, how does this model affect families? How does this model affect individuals? How does this model affect taxpayers? How does this model affect the state? How does it affect providers, et cetera? What's your reaction to that proposal? That would look quite a bit different from what we have here right now. Any concerns about that? Yeah, Carrie.
I consider it complementary because that's one view, which is good, but also starting to look at implementation or what that might impact. It's always good to have the opposite point of view to make sure they're tying out and driving the effect that you actually want.
So it sounds like, Carrie, you would see a value in doing both in our assessment criteria.
Well, if you have a criteria, and one of the things I know, the more benefits you put in there, the bigger the cost, right? So what does that actually mean to a family? That may be when we're designing benefits that we want to include everything because we love people, right? But we obviously have to make sure that it's affordable in some way too.
Okay, so it sounds like you see there's some value in that measure because you might see, for example, if we put a lot of benefits in and it's an employer-based system like what we have now, then that might, this is just an example, but that might look really good for a family and really bad for an employer, for example.
Both.
Because, an employer can only pay so much, and then they pass it on to the family.
Fair point. Yeah, so there could be an impact there too.
Impact is impact.
Okay. Yes, Dr. Dietering.
And I think it would help to focus, to understand the feasibility, right? It might, I agree, you could say this would be great for these groups, but kind of bad for these groups, and that would impact the feasibility of it being able to be something that could work in the state. And so it could bring out some important points, I think.
So you see some value in being able to compare how different models might affect different categories or groups.
Yeah.
Okay. Other folks? Anyone have any concerns about taking this approach? Dr. Kovar?
I just think that's begging for, what's the list? Where does it stop? You mentioned 3 or 4 obvious ones, and the list goes on, and then you just end up with a lot of special interests that will could potentially derail the process. I could name 30 or 40 or 50. It's infinite.
So you see a slippery slope here.
Slippery slope.
Okay. Do you have so it sounds like you would be more comfortable sticking with the way this is modeled now?
I think so.
Okay. Any other reactions? Oh, sorry, Patrick.
Thank you. Not having been in the Yellow Group, I guess I'm still a bit unclear as to how some of the value judgments might be attributed to a so-called benefit or cost to a particular group. So are you envisioning having something more data-driven first before a value statement is attached to it? Or could you help flesh that out a little bit as to what does it mean for it to be good to an employer or good to a family or good to the state or bad for you.
How do we actually measure this?
Right.
Okay. Anyone from the yellow group want to, maybe I'm looking at Jane because I think that was a proposal you had. Any ideas on how you might approach that?
I agree that each of those groups are going to bring different perspectives in terms of what's affordable for them. And so the reason that I was saying look at it from the perspective of each of those groups is to be able to acknowledge that a model that might work really well for individuals and families is pretty crappy for employers. So that was the thinking. It's not like one model has to have the same impact or the same positive or negative impact on each of those perspectives, if that helps.
Please, Patrick.
I would agree that, in theory, that the impact would be different among the groups. Again, I'm just kind of curious, how do you measure whether it's crappy for one or not, to use your
My
artful
New York
language.
vernacular.
Scientific measurement.
Well,
for
I mean, it's
instance,
just look, how does it compare to, for example, how does this model compare to what employers are currently spending on health benefits and how they spend it? How does this model compare to the percentage of income that a family currently would be spending on health care? So I think you could be sort of quantitative about it.
Okay, well, the quantitative makes more sense than qualitative or trying to assess a value on it. I mean, for instance, with the work that's been done on the standard benefit design, I think there are some folks that may say it would be a benefit to pay slightly more in order to get coverage they could use and a suite of benefits that were more relevant to their needs. But that obviously is going to vary from individual to individual, family to family. So I hope that we can stick more to data points and allow some of the analysis to be done by individuals as opposed to trying to determine in advance that a particular change in cost may be beneficial or detrimental.
So, Patrick, I'm taking away from your point that if we can have some quantitative measures, some data that we can measure against each other, that would be more valuable than value judgment or subjective measures. And this actually brings to mind something I wanted to mention too about what we're going to do with all of this information and processing. We are going to have to run it through the lens of what's actually feasible to measure, and there are going to be some criteria that we've come up with today that we would really like to know the answers to, but we don't necessarily have a way of measuring them. So we're going to note them, but there may not be a feasible way of measuring them, and that's one of the things that the project team is going to do as a next step with all the information here. So I think what Patrick just raised today about how we measure things, similar discussion that we had in our group about measuring quality, there may be some challenges with some of the criteria. I don't know any specific ones yet that I can call it as an example, but that did bring that up. Any other feedback on, excuse me, on the proposal to simplify or to add a measure of how a different model might affect specific groups? Yes, Karen.
I was just as you were saying that, it came to mind. We were talking about employers and that, but we will always still have people who are working 1099, who are individuals. So I think that needs to be called out because what it comes down to, and something we didn't put on any of the sheets that I heard, was the ability to negotiate, right? So if we're talking in some of the plans, a company gets a discount. Well, I had my dentist just tell me last week that, yes, we charge everyone without insurance more in order to pay for that discount. So we need to eliminate that. I mean, the people that have no negotiating power should not just be automatically forced to pay more for somebody else's discount.
Okay, that sounds, I kind of heard two really important points coming out of there. So one is some kind of criteria that keeps things equitable. And I think folks talked about that, but you added a different nuance to that, which is right now the current system, people get charged differently based on who they are and who they're working for. But the other point that I took away from that is, and this I think gets maybe to Dr. Kovar's point about this potential slippery slope here, is within different categories like employers, there are going to be subcategories that are where they're going to have a very different experience. And if we just aggregate that, we might be missing something really important. Is that accurate?
Yes.
Okay.
I had a question about that.
Yes, Kirsten.
Isn't there any data available what's considered affordability for populations and what's acceptable to providers and provider organizations that's already been done?
You know,
or are we
had
going
that-
to break into brand new territory on this? I would think that's already available just by looking at the reluctance to accept Medicaid and Medicare clients in primary care practices. But I'm not sure what's available.
So you're
out
asking
there.
if for these different potential groups, if there's some kind of
Yes.
threshold that's already been established. It's funny, we had that very conversation in the yellow group. Does anyone know the answer to that question? We didn't have the answer off the top of our heads. We assumed yes. We just didn't know for sure. Aaron?
Well, I mean, I know that studies have been done based on thresholds of household spending. I don't remember what they were, 10%, or I don't remember what they are. So those data exist, and some research has looked at affordability using those thresholds. As far as providers accepting Medicaid or Medicare, the caution there is that while those decisions are clearly business decisions, they have to do with more than payment. So, some practices find it difficult to deal with patients who are, quote, difficult, unquote. So payment is certainly one criterion, but there are other reasons that practices make those decisions.
So that might not be the right proxy for affordability, measuring affordability for providers, in other words.
It may or may not be.
Okay.
I mean, I don't know.
Okay.
Just on this point, while I think we should be concerned about providers' attitudes towards different patient populations and different payment levels. That's certainly valid, but to me, the primacy is on the affordability for individuals and families. And to me, the system, the purpose, that a main goal of the system is for services that are useful, that are beneficial, that was the term that our group used, are affordable over the long term for individuals and families.
I'm hearing you say, Aaron, and you're introducing a new point here, which is that we can measure how this impacts different groups, but ultimately you prioritize the impact on individuals and families over some of the other. If you're looking at the merits of a proposal, is that an accurate interpretation?
Yeah, it's accurate, but not quite full. I mean,
Okay.
so affordability at various levels are important. So affordability for individuals and families, affordabilities for businesses, affordabilities for government. All of those are very important components of this affordability.
So I am hearing I'm also seeing some other comments, I need to take those, but I am hearing some agreement that if possible, with some cautions like what Dr. Kovar raised, if possible, it would be useful to have those thresholds on affordability for different groups and have some way of comparing different models and the extent to which they're affordable for those different groups, recognizing that we could create a slippery slope if we get too granular there. Dr. Tritko?
It seemed that the discussion changed with the last person, but as a physician whose COBRA is going to run out next year and I'm going to be banished to the exchange, what scares the death out of me is charges. And there's been a lot of studies on charges, particularly with surprise billing. And there is a database, it's called Medicare, and anybody has access to it. And so I think part of what you should look at is under affordability is what are people charging, particularly hospitals, what are they charging everybody, and how does that compare to the data that you can get when people are in network versus not in network? What I'm being told is that the range is tenfold, so it's huge. And for people who maybe in a limited network plan, it's scary.
Dr. Tricco, I want to make sure I'm tracking, and I know we're going back to the question of affordability in general. I want to make sure I'm tracking, because when I was following what you were saying, I thought we were talking about how we might compare the affordability of different models, but then I understood your point to be more about affordability. There's some complication there because of whether or not you're in network or out of network when you're receiving services.
Well, we had talked about, as I recall, from over here, is what are people getting charged, and is there data out there? And there is. Everybody has Medicare, and they submit to Medicare charges, not what they negotiate with Medicare or the limiting charges, what they're actually charging. The assumption is they're charging everybody the same. And so this has come up with the surprise billing studies because people have suspected, and it's true, that various providers charge a lot more than others.
Okay.
And so there's a range there. So this may be a data set that you could look at potentially. In the meantime, what's easier is just get rid of limited network plans, so that's not a problem. But until we can do that...
Okay, that helps me, because I was thinking about when we're measuring models, against each other. For example, if we're looking at a model that doesn't have in-network versus out-of-network plans, then that eliminates the point that you just raised.
Well, I would just point out in Spokane, I have only limited network plans available to me in the exchange. There are no broad network plans. Whereas in Arizona, where I'm living now part-time, I can buy an Aetna or United. I can get an expansive network. I can't get that in Spokane. And therefore, I'm going to be likely subject to charges, far more likely if I stay in Spokane as opposed to move, which is not a good option.
Yeah. I'm going to move us along here. Dawn, you had a point, and then Beth. Nope.
And maybe I don't know what I'm talking about, but community health centers, collect similar data, and they're required to by federal law to collect it, and that's exactly how we determine our rates. And maybe somebody should take a look at how community health centers deal with this and go forward from there.
So again, I want to make sure I'm tracking. I think we're still talking about how we measure affordability for providers.
That's exactly
and you're
right.
saying that maybe that if we use community health data.
They have extensive data on both affordability and also on quality and how all that interacts. And we've been doing it for years. And other healthcare providers don't do that. And,
so when we're thinking about feasibility of how we measure some of these criteria,
the results are sometimes really surprising. I mean, it's
good to know.
I hear a lot of reticence about giving away too much, and the evidence, I think, from community health centers is that the more you give, the less it costs, and it's just a reality. And we need to take a look at that and say, this works, and go from there.
Kirsten?
The same type of data is also readily available from Indian Health Services and tribally run program.
I apologize, Kirsten. Would you mind starting again? I got a little confused there.
Okay.
Yes. Yeah.
The same type of data is available through Indian Health Services and tribally run programs. Those programs are provider of health care and also buyers of health care.
So the tribal run services may also be able to provide us data for...
Yes. Yeah, what rates of cost are out there. And it's very true what the gentleman over there, can't remember the name.
Dr. Tricco?
Yeah, that the cost of what you're buying can vary tremendously. And the kinds of surprise billing that's going on is also very common, which means that you may have a plan that usually can buy you a rate or a cost of health care if you're within network. That's not made clear to patients a lot of times when they access urgent and emergent health care, and you end up with a much higher cost than if you would have ended up having your emergency where you were close to a network hospital. Unfortunately for you, you are not. So your bills are going to be 65% or 70% higher And that's
Yeah.
something the patient would need to eat. I still think it's really important, though, to keep in mind the quality of care strongly linked to the affordability. It's one thing to make healthcare affordability, but you're still going to have to market it out there and get good quality providers to stay in the state of Washington.
And I believe I heard that, at least from the Green Group, if not also from the Orange Group, that any kind of effort to do cost control had to balance that with any impacts on quality. I'm just going to double check again. I thought Beth said you weren't going to speak. Is that right?
I think, too, as we're looking at more and more data sources, which I think are absolutely the way to go, we're going to have to just verify data validity and just how people are interpreting data, both from the CMS websites, from other websites, and even different provider directories. Because I'm actually happy to tell you, Dr. Trico, that Ambetter by Coordinated Care has both systems in Spokane in our network, and so we actually have a very robust network. And so it is something that you have to take a look at, kind of making sure that we're looking at all things the same way, and that we're looking at the same data sources, and it's clear.
So the caution there is if we're piecing together data like from community health centers, from Medicare, from Indian Health Services, that we also need to make sure that it's data that can be integrated, that they're measuring the same things. So I'm hearing that correctly. Okay, I'm going to take Dr. Kovar, and then we're almost out of time for this discussion. We'll need to move on to our model discussion. But Dr. Kovar?
So my disclaimer is I work in a community health center, but I know a lot about the inner workings of it, and I want to, the piece that my colleague who crunches numbers there understands very well is we have data on both ends. We have the data from our unified data sets that we have to produce by federal regulation. But on the other end, we also have to produce the cost of care. We have to show the staffing and all of our costs of providing it. It's a simple equation that ends up in our reimbursement. It provides our reimbursement rates. So that is how we get paid for the services. We have to justify it by this is what it costs, this is what we're getting reimbursed, and it's recalculated on a yearly basis. And so that's called cost-based reimbursement, and it is very transparent, and it's very visible and scrutinized by the government payer, so that you can't get outside the envelope, it just won't be reimbursed. It's an insanely there's data and there's work to it, but it is a very rational system. And if the Indian Health Service does it as well. And so if we pool that kind of data, and that becomes one of the aspirational things to do, that the rest of the health system has to justify their costs and their charges, you get rationality out of that.
Okay, so I'm actually hearing a new point here. So this is not just about finding a rich source of data for which we can measure and compare some of these models, but also an aspiration for our future system for how data can be collected and measured, and
exactly.
Also result in some cost control and without compromising quality.
Right.
Okay, great. Kristen, did you have another comment, or is that your old one? Okay, I'm going to check and see if there's any. Oh, yes.
I'm going to take chair prerogative here to
You
just
get the
say
prerogative, yeah.
There's been a number of comments, and I think we have to be very careful, because I think there's been a few comments too that don't discern cost and charges. There's been, these are very unique systems, the federally qualified health center financing system, Indian Health Service system. I mean, absolutely, your points are well made that all of this has to be heaped on, and things are very different and calculated in these different systems in very different ways. So I do want to clarify, though, that we have to get very clear about costs versus charges and reimbursement models, and our experts over there are nodding their heads as you all have made comments, but there's been a number of comments here that are factually not clear or confusing, but I can assure you all that our experts will continue to lead us through, and we'll keep sussing out some of these terms that I think lead to a lot of confusion.
And that was actually a perfect segue to my closing remarks on this discussion, which is, as I mentioned before, we're going to be taking all of the information you generated in your breakout groups and during this discussion and processing it to do a proposed revision to the assessment criteria that that I will send out to all of you for your review and feedback, as we did with the root causes back in December. But one of the, as I mentioned, one of the key lenses that the project team's going to be looking at the criteria, and that's going to include the actuaries, is this measurable? And I think Sue raised a really important point about making some distinctions between, and this is getting above my knowledge, but making some distinctions and being really clear about what we're talking about when we're speaking to costs versus charges, I heard you say. So any questions about our next steps on how we're going to process this information? Okay. Thank you all for a really good discussion, both in the breakout groups and in the larger group. Thank you for your flexibilities. We had to do a little shuffling to manage our sizes. I'm going to turn it over to our project team, who's going to do some presentation on, we're going to be talking next about the models of universal healthcare. So let's get this projector warmed up here.
Does everyone have a copy of the slide deck? We don't know how to make this, you can't get the screen bigger, so our apologies. You can go to the first slide. All right, are we ready? Okay. So I'm Janine Smith from Health Management Associates. What Nora Leibowitz and I are going to do is kind of walk you through some high-level overviews of some of the models. We are going to start with a very, very high overview of some international models, and then Nora is going to move on to some of the more major universal coverage models or thinking about universal coverage models in the United States. And I think one of the key things, as you saw in the assessment, is that there were sort of clumps, right? Who's going to be covered, what, how is it going to be delivered, what's being delivered, and so you'll see kind of that on your matrices that you all have. We sort of have those kind of categories along the left-hand side, and then the models across the top. So eventually, this is kind of the way you're going to be looking at models that you've framed up, and so we just wanted to give you kind of a context view here. So next slide. So if you look across, and I also want to caveat that this is not a super major, there are probably experts in this room on some of these various models, but we tried to give you kind of an overview and sort of a general framework on how to think about the international models. But most of them, oops. We don't want to, yeah. So there's basically four main approaches if you look across the international communities on what kind of healthcare models they use. There's either a single-payer national health system, affectionately named Beveridge, and there's it's on your sheet as to why it's called Beveridge, Sir William Beveridge. A national health insurance model, and there's a distinction we'll go through in a minute, and then a social health insurance model, which is belovedly named the Bismarck model, thanks to General Bismarck from old days of World War I, Prussian War maybe, and then the sort of out-of-pocket market-based model, which is kind of what we have here, but it's also things that many of the more third-world, quote-unquote, countries also have, where you're really basically paying out of your pocket. And if you have money, you get care, and if you don't, you don't. So if you look at the beverage model, the government is acting as the single payer through the establishment. They're both being a payer and the delivery system. So it's established a central national health service. So the United Kingdom, England comes to mind there, where not only are they the payers of the insurance, but they are also the ones who hire the providers. So they run the hospitals, they run the clinics, etc. So it's also similar to what's done in Ireland, Denmark, Norway, Sweden, New Zealand, Australia. Cuba is another example where it's very centrally run by the government. And if you think about these, a lot of these have evolved back in the days of the history. And I think one of the articles we suggested for this meeting was Atu Kawande's article that I would point you all to, that some of these models have evolved because of the cultural shifts and changes that were going on in these countries at that time. Or they looked, to England, had started this way, so why not do it in Ireland? The National Health Insurance Model is a publicly run insurance program, so the government is paying for the insurance, and through taxpayers pay into it, but they use private sector. They don't actually set up a delivery system, so it's not owned and run by the government. Examples there: Austria, Germany, Belgium, Japan, Switzerland, France, and the Netherlands. So the difference here is it's a single payer, but one owns the delivery system and one just pays the delivery system. General Bismarck's is much more decentralized even further. So if you kind of on a gradation, there's sickness funds, and they're more regionalized. So if you live in a certain part of Germany, you pay into a particular system there. That it may be a little different than if you, say, in Berlin might be slightly different than in a small town in a more rural area. But the employers and the employees both fund that. Then private insurance, there is also then they create sort of private insurance that covers everyone regardless of pre-existing conditions. So you've had both the payer and the delivery system together was the first one. The second one is kind of more nationwide. And then in these countries, Germany and Austria, it's much more, maybe more by state or by county or region, more regionalized, and it's very different. One sickness fund maybe pays differently for things than others, but it's decided there in that region. And then the out-of-pocket, market-based is in some ways what we have here. Wealthy are able to purchase commercially offered insurance, and there's increasingly more of that down in the South American countries, in Uruguay, for instance, in Argentina. And then, or if you don't have any insurance, you just have many more challenges trying to get care. So I think, but I think to think about it is, the population served. So these are all universal, but they serve the universe differently. The benefits are very different as you go through. The National Health Service in England has evidence-based decision-making on what benefits they're going to cover. I know in Oregon, where I'm from, we use that to create our prioritized list of services that we provide to our Medicaid clients. The administration is different, so when you're running the system and the hospitals as well as the plan, that's a different kind of administration than if you're just versus the sickness funds are administered on that local level. Provider reimbursement is different. In England, for instance, the provider reimbursement is your salary as a National Health Service core provider, versus if you have universal coverage there and they're buying, there may be a more universal rate, and I certainly don't have the details here available for you, but the reimbursement differs, even though it's universal coverage. And then mandatory or voluntary participation is another. If you're out-of-pocket model, obviously it's more voluntary, versus in England, it's everybody has access to it. And then who pays and how it's collected, how the taxes are much higher in many of these countries because they're paying for this additional benefit, just like we pay for many other things, but maybe to cover Medicaid and Medicare, but their taxes are often sometimes much higher than ours to pay to afford all that. So I think as we think about these, we just want to think about, what's feasible. Again, pointing to Atu Gwandi's article, these sort of evolved over time, considering the circumstances in these particular countries. And as countries have evolved and gotten, such as South America, some of those never had insurance, and now more and more of American health plans are going down there as a new market to introduce commercial market. I think in some of these countries also you can buy private insurance to get even additional coverage beyond what the universal coverage is. So there's an evolution that has happened in many of the countries as well. So it is hard, though, to lift and drop, say, England's model on Washington State, because that would mean there wouldn't be FQHCs and RHCs and private practices. You would all become employed by the government, and all the hospitals would be owned by the government. So it would be a very, very dramatic change versus a more evolutionary change. Might be easier with some of the other approaches. Sue.
Jeannie, isn't it fair to also suggest that many of these systems control for health professional education in a different source of funding mechanisms? So, for example, Cuba is training grounds for all of South America and globally does a lot of work. In the UK, it's based into a different part of their national budgeting system. So it's my understanding that the healthcare professionals and health workforce are also dealt with in a more national perspective as well.
Right. I know, like in Mexico, it was on obligation that you would work in a rural clinic as you came out of medical training, and you had to do that first before you could go and have a more lucrative private practice. You had to pay back, similar to our National Health Service Corps type of situation. So yeah, some of these models also would involve a more aggressive change in how we develop and build our workforce as well. So next, is it switch over? Is there questions about the international? Yeah.
Okay, so before we move on to domestic models, any questions about what Janine's presented? Yes, Aaron.
So it's not really a question, but I think this is really important information and useful for the work group's deliberation. I think in part because, we need to have a vocabulary that we share. And one of my concerns is, and I said this to you, Jamie, on the phone, is this term single payer. I don't think, so in common language here, single payer is what we otherwise would call a national health insurance program. Most of us think about single payer being what happens north of the border, okay? Not a national health service, which is a very different thing. And I think it's important, very important for the language to distinguish between those two things. So National Health Service in England is not a single payer. It's a national health service, which you accurately described as the government owning the means of production, right? That's different than what happens in most of the Canadian provinces, other than Quebec. So I just think it's important for us to distinguish that, and this isn't. I can sound like an academic really easily, but I think it's important for us to have a common language that accurately reflects the structure of these systems. So just to say that we should be clear about these terms if we're going to start using them in this discussion.
Okay, a couple of key points I think generally that we need to have common vocabulary and be clear about what we mean when we use specific words and phrases like single payer. And the second is drawing a distinction between single payer and National Health Service. Do you have anything you want to add?
Because when you go into the National Health Service in England, there's not a bill created. You're just going into what's already sort of prepaid, in essence, right? They don't check your insurance. It is very single payer means a lot of things to very different people, and we had those discussions in Oregon as well, as what does single payer really mean, which gets us to the frameworks that you're going to develop to clearly define that so it's well understood when you submit your report to the legislature. Sue?
So could I ask that maybe, because I thought you broke it out very well when you talked about delivery system, so that when you suggested that in the UK they own the delivery system, that we all get very clear about that distinction versus the administrative financing part of the system. So I think that is the way to bifurcate this so that people feel like they've got that clarity. And to my point about GME, because it hit to my friends down here at this end of the table, people don't think about all those other costs and supplemental payments that FQs and hospitals, or how we build that into the reimbursement methodologies. That I have now confused the whole group, but we really need to, in these comparisons, understand that there are these other massive amounts of resources going into fund their total system, not just in their national health delivery systems.
Okay, I want to make sure I'm tracking here too, so that.
Jeannie's got it.
Okay, but let me just do a quick interpretation, and then I'll hand it back to you. And I've got a couple more comments over here as well. But I heard Sue draw a distinction between delivery system and the payment system. I also have a suggestion that we might want to continue to add to our glossary that we prepared for our group at the beginning, and we can bring or send new versions with some of these additions. Okay.
No, I think what you're saying, Sue, is that the investment isn't just for the services being provided to the person and their family. Their investment in England is running a hospital, running a clinic. All of those costs are sort of shifted over to where it's in the government's pockets to do, rather than in Washington and Oregon and California. It's in, there's more private business entities that own those, some for-profit, some not for profit. So yeah, the funding, myriad of funding that fuels our delivery system is very complex, and I think that's one thing to think about for the framework of the models you select. It's, are you looking for something that is universal coverage and paid for in a more consolidated way than having multiple different payers, versus are you also saying or not saying that you don't want to necessarily disrupt the current way it's delivered, care is delivered, or who owns hospitals and who owns practices? Is that?
Yes, and again, the burden and the compensation related to healthcare workforce, professionals, and support staff, that has to be sussed out because of all the supplemental payments that go on in our country.
Right.
I want to make sure, because I think we've covered a lot of ground in just this quick interchange, and I want to make sure we clarify some next steps on addressing Erin's comment. So a couple of things. We want to be really clear when we're using these broad categories like single payer, for example, what we mean specifically. I understand that there are some distinctions we drew between the delivery system and the payment system, and I understand that I understand that. I want to make sure I'm capturing what Sue just raised at the last point about all of the implications of different methods of payment systems. Did I miss that? I'm trying to summarize for those of us who are more lay
That's
folks.
correct. We need a clinical service delivery payment system. In addition, though, this team also has ways to suss out the payment related to health workforce needs, because it's very commingled in our country in a variety of different ways.
Okay,
and it's
excellent.
very different in these countries as well.
Okay. So getting back to Erin's original point, I just want to make sure we've adequately, I'm seeing a shaking head, adequately addressed, because your original point was that you would not categorize the National Health Service as a single payer system. And generally, you would like to see clarity as to what we mean when we use these bigger categories.
Yeah, I mean, just basically, I don't think we should use single payer to characterize the National Health Service. It's not. But the other thing is, I would say that in terms of this slide, what we should add to this slide in terms of program elements is the nature of the delivery system, which you appropriately highlighted in your review of the 4 different models. So you can have a delivery system that's all private, even if the financing system is public. Or you can have a delivery system that's, well, you can have the opposite as well. It'd be kind of weird, but you can have the opposite as well. But those are two different variables. So, and this slide ought to reflect that.
All right. I'm not sure whose sign came up first, but I'll take Kelly first and then Dr. Tritko, and then we'll move over here.
Okay, just to beat a dead horse a little bit, because I just want to make sure everybody's really clear on that slide. Now I'm not clear because I'm not finding. So I would propose that on this slide, international approaches main menus, that we strike single payer from that column, and then we strike national health insurance and put single payer model. Is that okay on that second slide?
Some of the resources I used, this is how they characterize them. These are the words, some of the words they were using. But I understand, Aaron's comments.
It confused me too. It confused me too. Yes.
Yes.
Thank
so
you.
So it's national health system is the beverage model,
Yes.
and then there's a health insurance model that is. I get the distinction there in the national health model versus the third one is that it's national, meaning that it's across the country, as opposed to the sickness funds in Germany that are often very regional.
Regional. Okay.
So that's why I use the
fine. How
term
about
national there. Yeah.
And then there was something else you said. Oh, in Canada would be which one of these four?
Canada is a little bit of a mix in that it has, like the Quebec province gets gets money, and they sort of decide.
Always the Quebec.
Yeah.
Distinction, right?
And British Columbia as a territory or province gets their lump of the dollar. So there's some of these are, again, these are very general categories, and nothing, everything's got its own uniqueness in those individual countries.
Okay, I just wanted to make sure I understood. Thank you.
Okay, so it sounds like we have some edits we'll make to the slides, and we can get them back out to you so we can clarify those distinctions. Dr. Tritko.
And I would propose that our current Medicare system is a national health insurance model. It's not single payer, and that there's a variety of financing mechanisms. You have a variety of entities that administer, whether it's Part A, Part B, or Part C. So when you hear single payer, people think Medicare. I don't think that's the case in our country. It would be closer to the national health insurance model.
I think if you look at your matrix, we did that. There's similarities in the U.S. So the National Health Service is kind of like the veterans, right? In order to get your veterans, well, there's variation on that too. On your matrix that you got, on the first page of international models, high-level overview of international models, it says beverage, National Health Service model, Bismarck model. If you go down, similarities in the U.S., so the National Health Service is the veterans. Now there's some variation now because there's been such lack of access at the veterans that they are now allowed to go outside of the system. And then the National Health Insurance model, we did put like Medicare, and then the Bismarck model is similar to, sort of similar to some aspects of, each state has their own Medicaid, so there's sort of regional, like how we do ours is very different than Arkansas, and an employer-based system.
Okay, we're going to take Carrie, excuse me, and then I'm going to need to move us along.
Hopefully a quick question. I'm just curious, since the Bismarck model is Germany and Austria, and they also have a national health insurance model, how do those interact?
There's sort of a mix between those two. Like I think I noted on here that some started with Bismarck and then added features of the other model, and some started with the other model and added features of the Bismarck. So it's not totally pure and clean, but it was an attempt to, if you want, or a lumper or a splitter, I sort of lumped them.
Okay, I'm going to try to move us along now so we have enough time to cover the domestic models. Okay, Nora, you up?
So Janine noted that unlike the international models where there are models in action to point to, there's no universal coverage, all populations existing in the U.S. states, but there have been a number of proposals, including legislation considered by various states and passed by various states, proposals that have been assessed by states, et cetera. So we, and then both California and Washington, we're including some less than universal coverage, but kind of working toward more coverage overall that we've included in our discussion. So we were focused on states that have been talking about universal coverage in one way or another, and in order to make a table that didn't have kind of every possible example, I just want to note ahead of time that, you know, in states like Maine and Vermont, they went through several iterations in their legislative work. So for those of you who are experts in this, I recognize that we just had to pick an iteration and kind of go with it in order to give an example, but recognizing that for particularly for Vermont and Maine, there were multiple steps in the process, and it didn't look the same all the way through. So we looked at these states: California, Maine, Oregon, Vermont, Washington, and then one of the challenges to doing this work is that the level of detail in the proposals was varying across the states. So even in states like Maine and Vermont, where they passed legislation, you know, as you can imagine, getting legislators to all agree on the specifics was sometimes challenging. And so there were these pieces of legislation that were passed that say, we're setting up this organization, and this organization will make the following decisions. So you'll see in some of the cells in the tables that there is a little bit of tossing things down the road as the legislation put that responsibility on a group. So these are some of these things I know we all have talked about today in the small groups. Some of the issues that have come up in designing universal coverage, including administrative complexities, and as we've talked about, that's, you know, at the level of the consumer, of providers, of the government, employers, et cetera. Thinking about moving from what exists now to what could exist, and the disruption that will happen. And I sort of use that term without meaning it to be positive or negative, just saying there's some change that obviously takes effort to make change, including what's happening and whether you build on what you have now or you completely move to something new. And a big piece of that is public perception. I know in the Green Group we had some conversation about both political and other public need to think about the changes, as well as administrative issues, including around the ERISA and large employer coverage, the Medicare program, et cetera. What funding means, both at the system and the individual levels, and then thinking about ongoing revenue and financing. So again, Janine had mentioned some people are splitters and some people are lumpers. And so we have kind of tried to make the table that you all have kind of go from left to right with a more similar to the international models, a more government-involved system to either sort of less involved or smaller program change. So the sort of three categories are government directly administering the program, government setting the rules and having an oversight role with private administration of the delivery system, and then building on existing programs, sort of adding programs or adding eligibility, that kind of thing. So this is just kind of getting at what's in the table, saying that under the directly administered a program by the government was this. That actually should not say healthcare ingenuity plan. It should say Oregon single payer proposal. Sorry, I just realized I was like, that's not what that is. That in the study that Rand and HMA did a few years ago, looking at the impact of a couple of models. One was a single payer proposal that was much more. The government sets the rules and everybody is using one organized set, and the plans are contracted with the government, et cetera, versus the Oregon Health Care Ingenuity Plan, which utilized more private plans, but with the government having a set of administrative rules, et cetera, and deciding what the benefit package would look like, et cetera. And then that's kind of where the Washington Health Security Trust Bill also kind of falls in terms of, and recognizing that's sort of a legislative proposal, and that you have standardized benefits, you have it covering all state residents, so it fits into that, the more universal coverage, but not as fully operated by the government. And then a couple of existing programs, both the development of the public option in Washington, Cascade Care, and the newly implemented changes in California, which include, so the state decided to have an individual mandate with a penalty associated for not having coverage, and with that they added state. On top of federal tax credits, they added state financial assistance, both for lower income people, but also for people at higher ranges of income who were dealing with the fact that they were paying for most or all of the cost of their health insurance and finding it unaffordable. At the same time, they have enrolled more young people up to 26 who are low income in the Medicaid program without regard to their immigration status.
Excuse me, Nora?
Can I just would like to make a kind of a point of clarification.
Yeah.
Because these are universal, most of these are universal coverage. But the last two, one of which I'm very familiar with, these are really designed to address problems within the individual market, and they are designed to help the smallest segment of the insured market that exists in these states. And our state, it's less than 4% of people could possibly be impacted. I can't speak for California, but it's probably comparable.
Yeah.
So they were never intended to be universal.
No.
programs.
And I'm sorry if that wasn't clear. What I was trying to say.
But there's been
was
so
that.
much confusion about these different models. I felt like, and public option as well. Just it's getting thrown around nationally. I felt like it's really important to make that clear.
Yeah, no, absolutely. I think that's a really good point. That just to be really clear, those last two options are not intended as universal coverage, and they are part of what's often seen as how do we fix the gaps that exist in our current system in a way that's incremental, I would say. And yeah, I think that's. You're in a particularly good place to know the impact of the Cascade Care population. And in California, the scope of everything in California is bigger, but they, like Washington, are trying to get at affordability more than on insurance, really.
There's another point of clarification.
Yeah, I mean, part of the reason that we included it is we wanted to acknowledge that Washington has been taking steps that are related to, to health reform, and that we didn't want to just kind of ignore what's happening now, recognizing that a lot of people do know that Cascade Care is happening, and wanted to talk about the fact that there is interest both in universal coverage in one big leap. And then there are also folks who have expressed interest in kind of how do we make incremental steps to change what we have now into something that covers more people and makes care more affordable for more people. Yeah, of course.
I'm sorry, the previous slide you mentioned the Washington Health Security Trust, and it is not a multi-plan program. It's only one plan, and I think there's people here that can even speak more to it than I can, but it's just one plan.
And you're talking about the benefit package or one organization?
It's one insurance plan.
Okay, so this kind of gets to the previous conversations that we were having about the delivery system and the. So there's maybe go back to thinking about there's benefits, what's the package and what's the cost and those things that are organized by the state, and that's one package that everyone would have access to, which is separate from.
That's not the question. So if you go to the slide.
Yeah.
The next one, wherever. Next,
Where did it go?
Next one. Next one. Yeah. Government sets rules, oversees private plans. So the Washington Health Security Trust does not envision private plans.
Okay.
Yep.
Yeah.
That's a correction we need to make in our understanding of WIST, it doesn't fall under that category. So presumably it falls under the government directly administers category?
It's a category that's not.
It's a category of
there,
its own.
Government sets the rules and pays providers.
Okay. Government sets the rules and pays providers.
So it's like Canada without.
Canada without the Canadians. Okay, so to clarify what we have here, we'll make a correction to here that it's government for WIST. It's government sets rules and pays.
Would it feel better if it was instead of plans was, sorry, as I walk away from and blind myself, that it's the government is setting the rules and the providers are not government. Okay, not plans, but yeah. Sorry, yeah. Right. Right, yeah. Right. Right. It's yeah. Right. Yeah.
I was wondering why under the middle one, why you didn't include the excellent work that's been done in Maryland with the all-payer and total cost of care model. I mean, that actually has a long track record, and yet we seem to be ignoring it.
It is. It's actually interesting because it came up in the green group. Sorry, I keep referring to where I was sitting. I think the reason that we didn't put it in is because it is less about overall coverage than about how. So just as the quick and dirty version of Maryland, they have a commission, and so a hospital has to charge all payers and gets reimbursed the same amount. It doesn't matter if the person is uninsured, is on Medicare, is on Medicaid, has employer coverage, private individual coverage, et cetera. And I think it's really worth talking about. We didn't include it in this because we were thinking about kind of overall structure of coverage, and so that's why. But I think it's definitely worth talking about because as a model, it's something that other states have been interested in. I know, Western states have started to look at the idea of saying, well, why do we allow uninsured people to be charged more than people who have private coverage?
Okay, I'm going to offer a suggestion. When when I read the Urban Institute report that sort of layered each kind of reform on another to iteratively get to essentially what was single payer, the thing that was appealing to me about that is that I could think about what Washington looks like. So, for example, Washington has virtually universal coverage for kids, right? Our insured rate for kids is 98%. And so while I appreciate, bringing up California state subsidy, Cascade Care, I'm trying to figure out whether there's a way to build a base that shows where Washington has already come and think about, yes, we're having a discussion about do we want to go with something as far as the Oregon approach or the Washington Health Security Trust, but have a better understanding of the foundation that we're building from. And that does provide, like in the Urban Institute report, one of the elements they have is changing provider reimbursement rates. And when you look at how that impacts how much it costs to add all these people, but if you're also impacting provider rates, it sort of is a wash. That, I think, provides the opportunity to say also looking at things like the Maryland all-payer rate-setting approach. So I don't have it totally in my brain, but it just seems that if we can have a sort of a clearer understanding of the gestalt of Washington State, and that's our foundation, and then think about how proposals like this would modify and or build on it. That's just a thought.
So I think I'm here, and the idea came from the way the Urban Institute report built upon itself. But if I'm hearing correctly, Jane, it sounds like what you're proposing, and we'll have to think about this in terms of process and the final report, is can we establish what our starting place is and then look at these models in terms of how much they would change where Washington's starting, or what kinds of changes would need to be made to make this fit into Washington. It also might fit into the evaluation criteria, the assessment criteria discussion, to the feasibility section. To what extent do we need to change how we do things here to implement this particular model? Am I capturing that correctly?
Yeah, I think so, because it's like Kelly just said, something that may seem like a massive change in another state might not seem like a massive change here. We've figured out how to do universal coverage for kids, right?
Okay, that's fair. That's fair. I'm going to do a quick time check here. We've got about just a little under 20 minutes left. How are you doing on getting through the slides? I want to make sure we have time for more clarifying questions, too. We have a lot of slides left? Oh, we don't. Okay, good to hear. Then I think we've got everybody, so you can keep going. Okay, Liz pointed out that the Green Group did talk about having a pathway to implementing universal health care, and actually Yellow did as well. So.
Yeah. Right. Yeah. But now there's no lights. All right. Well, while we're getting all the lights back on, so this is something that that has come up in the small group discussions as well. Just the extent to which in defining models that will be assessed by the actuaries, that there are elements that are so-called moving parts for a model, some of which can be assessed in an actuarial context, and some of which are not going to be able to be assessed that way, either because they are more qualitative or because data have not been collected in those areas, even if they theoretically could be. So just recognizing that from the conversations that we all had earlier today, that that assessing the models is both an actuarial exercise, but also a discussion that the group will continue to have. And this is really, and feel free to come and jump over the table and push me out of the way if you'd like. Actually, I'm very excited to see that. In talking about what are those moving parts for the model itself, we've had conversations as a team about the elements that need to be defined, and really recognizing that those are the covered populations for any program. What are the benefits? And we've had some conversations in small groups about like how detailed that needs to be. As well as what is the program administration structure, the extent to which there are different health plans, there's direct contracting with providers, there's everything owned through the state government. And then how are providers going to be paid, recognizing that how providers are paid now is not a single answer, and that some other kind of key related issues are what's the funding sources for supporting the coverage program, which really gets tied up in is related to the issue of how much cost sharing, how much of the cost is borne by the participants, how much is borne by other groups, including the state government, including employers, are people paying through taxes? Are they paying at the point of service? Are they paying premiums, et cetera? So those are just kind of things that are in the discussion for models. I recognize that's all super fast, but you told me to be fast. So.
Okay, more clarifying questions or corrections or comments?
I'm not sure if I can articulate this that well, Mary Beth over
Mary Beth, sorry.
but Sue made the point earlier about the FQHC and some of the other models, including other costs for the system, whether it's workforce development or infrastructure, and this is paying for services. I mean, I'm not sure actually where those considerations would go. I don't.
Okay, I want to pare it back. And actually, can we clarify FQHC?
Oh, I'm sorry, Federally Qualified Health Center.
Okay, thank you. So this is getting back to some of the questions that Sue raised earlier about costs or charges that are not necessarily captured in. I'm not sure if I'm. Mary Beth, maybe you can. Did you turn? Oh. Yeah.
Sure. My name is Shane Mofford. I work with Optimus. We'll be doing the math. So I think part of the issue is that Sue was talking about the financing behind healthcare being fairly complex. That's both in terms of how you support the development of the workforce, but also in terms of direct provision of services. One of the key examples she gave was GME, so graduate medical expense, and for example, Medicaid agencies will make supplemental payments to hospitals to cover that. So when you're decomposing any sort of delivery system or financial system to support that, you have to identify and account for all of those different things. I don't know all of them. I know a lot of them do flow through Medicaid, and we are actively itemizing and finding data sources for each of them. But it's pretty complicated, and it's actually an area where we might need some support. So.
Are you talking about how, like, a cent goes towards the MRI machine? Is that what are we talking? I don't understand what we're talking about, I guess.
No, it's the use of residents and physician-provider training systems, and that all fuels huge costs. And there are other financing pieces of this too. Disproportionate share hospital payments for those hospitals that do more uncompensated or more Medicaid care or undercompensated care. So there again, there's a whole bucket of other supplemental costs that go in that don't get sprinkled evenly. So for example, in the Maryland cost model, and one reason I would be opposed to kind of just narrowing on Maryland, that is hospital rate setting. When we are talking about universal, we have to look at how we're going to change things for all parts of the system. And Maryland has some very specific things going on too with rural global hospital payments that are, I mean, they really have some cool stuff, but it's a very different environment where they have a lot of federal employees and different kind of mixes that Washington doesn't. So all these other kinds of costs and how they sprinkle out and how they cascade to these other segments, it's really important because it is probably going to drive another 30% of the cost detail.
And it's in one of those bulleted items. That's all I was wondering. I was just wondering if one of those bulleted items covers the complexity of that.
I think we don't know just yet how we're going to dissect those and then appropriately apportion them to these models. But I think, again, that's what we're bringing up is we got to pay attention to that because it's significant.
Right, because in Oregon, when we were doing the RAND report, you know, it was like, do you leave Medicaid alone and do something else over here? And it's universal, but it's for everybody but those in Medicaid and Medicare who are paying for some of these graduate medical education costs. So that pricing is different than if you know we're not going to do Medicaid, but we want all those dollars and we're going to distribute them differently. So it just is, how do you apply the framework?
But I see our really smart finance team over there shaking their heads like that they've got a way they're going to dissect out those buckets and somehow equitably put them into the right models and explain it to us as it's really big calculus.
Yeah, I just had two, hopefully this is clarifying. These supplemental payments, these dollars that you don't see in an average unit cost that are going to hospitals, FQHCs, outpatient care providers, we're gathering them because we want to understand the cost of care in the system. Now, how it's dealt with the financing and what is ultimately decided upon, that's going to be the legislature's decision. But we want to capture the dollars because they exist, but you don't necessarily see them. They're not readily reported, and they may be buried somewhere in national health care expenditures. They don't say supplemental payments to this hospital, but we are capturing it because we want to get the cost of health care in the system.
Mary Beth, did that address your question?
I think so, yes.
Okay. And Erin, are you satisfied with that, or do you have anything to add? You're okay? Okay. I'm going to talk about next steps, unless we have any final questions or... Okay, so, and I'll need your help exactly, but this is not next steps. Oh, thank you.
Actually, one more question.
Oh. Let's see, I see Bevan and then Kelly.
I guess this is more for you guys, but my question is, once we get the total cost, are we then going to evaluate potential savings in these different models compared to the cost?
The current situation?
Yeah, so once we have the current cost that we're already paying at the state level, individuals and all the things, are we then going to look at the potential savings in different models if we were to go to something?
So, okay, I want to make sure I understand the question. So once we have current costs and costs of different models, will we be able to compare costs and also savings?
Yeah, I think that's really important.
I see nodding from our team, so great.
So she wants to add a savings bullet.
Okay, Kelly?
Can we just come up with a name for that stuff you're talking about, Sue? Is it like cost? That 30% charges that she's talking about?
What's that? Non-service-based reimbursement.
Non-service-based.
Someone can come up with a good acronym for that. We're in business. Dr. Kovar.
One thing that struck me again, and if anyone didn't read the California Assembly's report, really go over it carefully. It was just so informative. But what struck me was the word single payer, or the pejorative, the divisiveness is not there. And I wonder if it's included in just this concept of unified healthcare funding. Right? I mean, it's just, there's a new term that you can't attack just on an emotional basis. It's unified healthcare funding. It's all sources, including these indirect CGME payments, and it's rolled in, and that's what has to be, in a greater vision down the road, have to be understood and captured to get to where we want to someday. Right? So it's a change in terminology, another way of And we don't have to separate out this very, very complex concept. It's just you're putting out there that there are sources that many people just don't understand and they're kind of hidden. But we need to but somebody knows all of them, and we just need to collect them all and come up with what's potentially out there someday when the regulatory environment changes.
So we're talking specifically about how we finance the healthcare system, rather than this fragmented system we have now, unified healthcare. Funding.
And using that term.
Unified healthcare
financing, as our California neighbors did.
All right. QH. Okay, any final questions or comments? And then I'm going to talk about next steps. Okay, so the next steps, again, the objective of this presentation was to get you up to speed on the different ways that universal healthcare could be delivered. We did get some feedback on some clarifications we can make so that this is less confusing. So we will make those and then resend the matrices and presentation deck so that you have those. You're going to be receiving, receiving a survey, and this is going to be your opportunity to provide feedback on what should go into the models that we compare. We have the ability to compare 2, possibly 3, but the 2 of those would have to be fairly close together, models. So we're going to take that input that you're going to provide on covered populations, covered benefits, program administration, provider reimbursement, financing, and consumer cost sharing. If I can envision what the survey will look like, it'll maybe have some drop-down menus where you can pick. We're going to ask for your input, and that's going to be one of the things that we use to select some models to evaluate and compare. We're going to bring your collected input to the April meeting where we'll have small group discussions to help develop the 2 models that we're going to compare. And that's what we're going to be doing in 2 months. Any questions about the process there? So when can we expect to get a survey out to them, do you think? Probably have to check with Katie. Yeah. Our fearless project manager is quite sick, so we're going to have to circle back with Katie and confirm when you'll be seeing that survey, but you should expect it fairly soon. Okay. Yes, Kelly.
So the survey, we're doing, what are we doing on the survey?
So on the survey, well, actually, maybe, Janine, can you I think I'm not being as clear about what they might see on the survey.
Well, if you think about the assessment list, we want to start sort of getting your feel for some of those modelable elements. So I think we've had some discussion today about what the covered population would be. Is it everyone? Is it everyone? Is it all residents? Is it so we want to kind of get a feel of the group, and where would you tell optimists how many numbers to put into their model, right? If you're going to maybe only do where a gap covering those who don't have insurance, only then insured. So it gives us a magnitude. We talked about the Washington's current approach to a more single, common benefit package. Is that what everybody feels like they want to have? And again, these are just your initial thoughts based off of thinking through these things a little bit today. And then we're going to have time. That's what next meeting's about, is to have further discussion. But we wanted to kind of get a general opinion rather than we don't have time to interview all of you again like we did at the beginning. We're trying to give you some very concentrated questions around these sort of categories of, based on and thinking back on what we talked about today in the smaller groups. What are your thoughts? And we'll give you some drop down, and then we can continue and bring back and say, 75% of you want to have it cover every single person, irregardless of residency. Well, great, we're done. Or in sort of thinking about that, and so that Jared and company could start to think about how they're going to model these models.
So it sounds like we're building the 3 different.
Yes.
Rather than maybe choosing some that already exist and saying, go with.
You're starting to frame up some models. And so then we'll break you into groups as we see what kind of the general feel is. Is there what are the places that need to be sorted through? And so is this so for model A would have these features? But a lot of you really would like to see these other features, so maybe that's Model B. And how do those Model A and B compared to what we have now is what we'll eventually get to. But at this point, we're kind of building Model A, Model B.
Okay, great. Thank you.
And I understand your confusion, Kelly, because I think in past discussions of process, we talked about evaluating existing models. And so this is a change to what I think has been talked about before. Yeah. Okay, let's talk about next steps, and then we'll move into public comment. First of all, I'm resending around the sign-in form, so if you came late or did not get a chance to sign in, if you could make sure that you've noted that you're here if you're a work group member. Couple of next steps. You're going to receive an email from HCA with the public comments early next week. Yes, ma'am. I think that would be ideal. We'll just see what the timing is. I don't want to delay the public comments. So if the timing works, we'll send them all together so you don't get multiple emails. If not, you'll get them separately. How about that? Okay. We are going to revise the criteria based on the input and the work that was done by the breakout groups today to reflect what you came up with and send that out to you for review. As I mentioned, you're going to get a link to the survey so that you can provide your initial thoughts on the models. And finally, we're going to make those corrections and clarifications that we discussed in the presentation to both the slide deck and the matrix so that you have those to inform when you're doing the surveys. Liz, did I miss any action items? Did I miss any action items for anyone around the table? Okay. I'm going to remind everyone about our public comment process. I have a sign-in form here with 4 people signed up. So I'm going to put it back there if anyone else wants to add their name to it. We have between now and 5 o'clock to do public comments. We're going to do 2-minute comments. I'll turn on my timer so that you have them. And then if you have written comments that you would like to submit also, we will make sure that those are part of the record and get shared with our work group. Any questions about our public comment process? I have a question, which is, are we going to use this mic or... Okay, we'll do that. We'll do a little modification for our approach here. Okay, so give me just a moment to fire up my computer, and then we'll get started with the public comments.
Okay, thank you. Hi, everyone. My name is Marcia Stedman, and I'm with Healthcare for All Washington. And I just have a few comments today. I think it's important that we not be constrained by existing incremental efforts that are currently in play. But I also think we have some very good existing programs that can be definitely built upon, and I was really heartened to hear everything people had to say today. Some of the comments were very enlightening to me. I really liked the childhood, 98% of children being covered for health care. I think that's very promising as a model. So I think it's really important to have a high-level view, though, at this time, and I was really impressed by the bipartisan, across-the-board opinions in the group I sat in on and observed that everybody seemed to have the same outcome that they desired, which is that the narrow networks weren't working for them. They were scared that they would be caught and have no providers in rural areas or have to pay those surprise costs. Even though we do have that new law in our state. So I would also like to say that what the legislature is doing right now in terms of the healthcare cost transparency bills is very important, and I really applaud the legislature for taking this tack in preparation for what this group will come up with. So thank you for everyone for what you're doing today, and thank you for allowing the public to be part of the process. Appreciate your.
So on behalf of the group, thank you for those comments and speaking up.
So David, I want you to start by stating your name and if you're representing an organization.
Yes.
And your comments.
Yes. Hello, David Loud. I'm with the Healthcare is a Human Right campaign, which includes a lot of organizations. And just one quick correction, I think, on the overview of major international models down on the first page at the bottom, the eligibility row. All legal citizens appears 3 times. Certainly in the case of the national, or some of the National Health Service plans or programs, that isn't the case. Anybody in the country, including visitors, is served by those systems. I'm not familiar with the details of some of that. I just want to caution that all legal residents doesn't apply sometimes. And we're here, all of us are here, because there's a rising tide in this country and in our state that we recognize that we need universal affordable health care as a matter of a human right. Not everybody sees it as a human right, but the expectation is high and rising. And we know that our state can't accomplish this by itself. So I want to second and applaud comments I heard from some of the work group members today that recognizing our limitations, we have to aim high, we have to aspire to the goal of universal affordable health care and figure out the steps we can take toward that. And when we do that, and other states do that, that actually helps move things forward at the federal level. So what we do here is going to influence the ability of our representatives in DC when we have, anyway, so what we do makes a difference at the national level. It works both ways. And so just keep up the good work, and thank you very much.
Again, thank you for those comments. And I don't think there's any questions from the committee that we're probing into, correct? We're just taking comments.
Just taking comments.
But thank you.
Did anyone else from our public want to make a comment today? Okay, well, thank you, everyone. Sue, do you want to say any parting words to everyone?
I want to, again, thank you all for being committed and involved and speaking up and having really positive civil discourse. It's really refreshing for us to be leaning in and working together. We can't have enough of that right now. And to our very capable supporters for teeing up the work and whatnot and answering questions and going along with us, thank you to all the facilitators and you, Jamie, as well. So please drive safely and stay dry and get out and get some exercise.
Yes, you just have 20 minutes you didn't think you had. So enjoy your evening, safe travels, everyone, and we'll see you in a couple of months.